Well, good day, everyone. Welcome to the latest edition of Infection Control Matters. Martin's with me today. Good day, Martin.
Hello, Brett. Nice to see you again.
You too. And guests from Ireland today. I just want to welcome Deirdre Fitzgerald-Hughes and Aoife Kearney. And Deirdre and Aoife are researchers in the Department of Clinical Microbiology at the Royal College of Surgeons in Ireland, the University of Medicine and Health Science. And Deirdre is a senior lecturer and deputy head of school for postgrad, and Aoife is a clinical lecturer and has almost completed her PhD. So how far have you got left, Aoife, in your PhD?
I have submitted my thesis, so I'm just waiting for the big day, the last kind of the viva. So we have here kind of, I know countries do it differently, but here we do the thesis and then it kind of gets examined by the intern and the extern. So that's happening in March. So I'd say nearly there.
Excellent.
Yeah, you're looking relatively stress-free.
Yeah.
Yeah.
How much you can do about it.
Long time.
It is, yeah.
And well, I'm sure we may well be getting you back on here to talk about some of your other work. Well, I guess I should start by saying we're going to be talking about a national survey of healthcare workers looking at CPE, and I won't really say much more about it. It's in press at the moment, the General Hospital Infection. We'll put the links up to the paper. Before we get into it, Aoife, was this part of your PhD studies, or is part of your PhD studies?
Yeah, so this was a part of my PhD. So the main focus of the PhD, I suppose, was looking at kind of drivers of transmission to patients in hospital environments of CPE. So we started to look a little bit at, environmental sampling, looking at kind of reservoirs, and then we were also interested in understanding, I suppose, activities that may help those reservoirs persist or may make them kind of more difficult to eradicate. And that kind of led us down this route of trying to understand, I suppose, just whether people think that sinks are an issue, especially people who don't work in infection control, and I suppose how they interact with sinks during the kind of normal course of their work. And I suppose kind of one thing led to another, and this is where we kind of ended up, was just kind of trying to understand it from them by doing this survey.
So where did it all start? Where did your interest start in the sort of CPE topic?
My personal interest, I suppose, started in probably like 2017, 2018, because I started to work in infection control research then. So my background is in nursing. So I had worked kind of as a non-IPC nurse for a good few years. And I was not that interested in sinks or CPE then. I was kind of more interested in other stuff. And then I guess I just became interested in the role of the environment in infection control because I had worked in a really, really old hospital. And it was just a daily challenge, I suppose, like trying to deliver like modern healthcare in just a really old building that was built like hundreds of years ago, basically. And then IPC came along, and then I became involved in a couple of outbreaks of CPE and doing some environmental sampling. And I suppose that's where I became a bit more interested in the CPE thing. And Deirdre had kind of done similar work previously as well. So we decided to apply for funding for a project.
I suppose that was about the time where you got quite a few national outbreaks as well, didn't you? And some quite large regional outbreaks as well, Deirdre, around that time, weren't there?
Yeah, that's right. Yeah, no, I was just listening to Aoife there. Like, you could say I kind of headhunted her because, our interest was in epidemiology of healthcare associated infections. But I knew that Aoife wanted to do a PhD. Wasn't quite sure she wanted to do it in this area, but, we eventually got the funding. So it really started with that. And as Aoife said, she started the project in November 2020. And we had, I suppose, a different project in mind in terms of, we were going to look in the clinical environment. We were going to look at acquisition. But it became quickly apparent that we weren't going to be able to get the kind of clinical exposure or access that we needed at that time. So like a lot of researchers during COVID, we had to really pivot and we had to think, well, what else can we do to address the research question? And I think that's where the survey idea came from. And I suppose Aoife, as you said, has a nursing background. And we had a lot of conversations about, you'll never believe what I've seen in the ward. I bet this is widespread. But, we really kind of thought, well, anecdotal evidence isn't really going to get it into policy. Let's try and do something to make this into some hard evidence that people will listen to. And as you said, I think the setting at the time, Ireland in 2017, were quite unusual in that in response to the growing kind of worsening situation with CPE epidemiology, they announced public health emergency in response to it. And that was at the same time that we launched our first national action plan for antimicrobial resistance. So I think we knew that we wanted to do a survey, and we knew that we wanted to try and find this hard evidence, but that kind of helped us to frame it in terms of the, we looked at, healthcare workers who had from 2017 on really were expected, I suppose, to interface with all of these new policies in relation to CPE. So we wanted to see how that was sitting with them on the ground. And as Aoife mentioned, she was also doing some research on looking at how CPE and sinks can thrive in the presence of high nutrition drinks and IV fluids and enteral feeds and all of that. And I think, the work of Amy Mathers as well came in. We talked about Amy Mathers' work a lot, and how, only 4% of the activities in an ICU around hand washing sinks were actually hand washing,
Yes, we've spoken about that a little bit, I think, in the podcast.
We have.
In the past, haven't we? Yeah.
Yeah.
So the sort of aim of the survey, how would you describe that? What was the general goal here?
Wanted to, understand like perceptions that, okay, it's going to be a long aim, but I suppose we want to understand and compare the perceptions of the risk posed by sinks, I suppose, or their role in transmission, and sink related behaviours between infection control and non-infection control staff. So I suppose we wanted to compare them, because I think when you speak to IPC people, there is an acceptance that like this is a problem, or at least something that they spend a lot of time thinking about maybe. And when it comes to CP outbreaks, or there's kind of a growing discussion about it. Whereas in our experience, when we presented some of the work we had, internally, maybe not to a specifically IPC audience, it seems like a really kind of out there idea, like sinks, like, it's really like whatever next, like will IPC come up with, like to make us afraid of. So
yeah, people think we sit in cupboards coming up with mad ideas, don't they?
Yeah, or hiding in a sink, like ready to, like, a new thing. So I suppose we just wanted to try and understand that in a bit more of a, like, slightly more, I suppose, like robust way than just kind of our experience, which was just trying to make this seem like a valid problem. Like that's how people kind of acted about it sometimes when we presented it, that it was this really kind of out there idea. So yeah, I suppose we kind of set out to do that, and we talked about different ways of doing it. If it would be better to speak to people in small groups, or if it would be better to just try and understand like a kind of wider, just get a kind of a sense of it as a kind of starting point. And that's what we decided to do, was just to do this kind of, look, let's just ask a lot of people who work in lots of different hospitals in Ireland what they think. And I suppose the anonymous survey we hoped would let people answer honestly, because I suppose when you ask people in the place that they work what their practices are, if they're not sure, they might just say like, oh yeah, we're not supposed to do that with the sinks, but oh well, we don't, but actually if they do, we just kind of wanted to understand that, I suppose. So that's kind of why we chose to do the survey anonymously as well.
I was just going to ask this before we get the results, maybe. So this was it going across 30 odd hospitals across Ireland? So it's quite a big coverage with your survey. How did you manage to do that?
We're lucky that Ireland is quite a small country, I suppose, but we had a lot of contacts, and we really kind of dipped into our network to try and drum up interest in completing a survey. I think this is our first probably experience of doing a survey-based research. So we went into thinking, of course, people are going to, respond to our survey, but we had kind of times of really good activity, and then it kind of, dipped down again. And so we did a mixture of things. It was kind of during COVID times, I suppose, as well. But one of our colleagues, Dr. Maria Boyle, who had worked with us in the past, has a really strong social media following. So that really helped to boost the responses. But then we also went the paper way. So Aoife contacted 37 acute hospitals across Ireland, and a number of departments within those hospitals, just to try and get the survey out. So we had a good spread, I think, in the end, and we got in total 283 responses. Most of them were medical and nursing staff, but we wanted, everybody to have a say. Like, we had been talking to dietitians, physiotherapists, so we got a good spread of people that, work on the wards in the hospital.
Highlights in the results then, Aoife. What did you find? What jumps out to you?
I think most people were aware of CPE. The IPC staff had more experience, as expected, of encountering it clinically than the non-IPC staff. there was more IPC staff that understood that maybe sink drains play a risk in the transmission of pathogens than non-IPC staff. And then when we looked at sink disposal practices, so we asked people if they discard things down sinks, almost none of the IPC staff said they did, but the practice seemed quite widespread of the non-IPC staff. And that included things like beverages, enteral feed, antibiotics, in kind of varying proportions of people said that they discard those things regularly. But what was interesting, I think, is that a lot more people said that they witnessed their colleagues discarding things like that than they do it themselves. So it does maybe indicate, yeah, probably like these are practices that are quite, maybe potentially could be kind of widespread, like in Ireland anyway. And then I think as well, what was interesting is that most people who said that they do that, so they discard things that maybe that they shouldn't, or that it's against policy to discard, they didn't report any infection control learning needs. So they felt like their IPC learning, they were all up to date with kind of IPC knowledge.
That was the bit that jumped out to me. Most people seem to think they knew enough, and I've considered myself personally to be the thickest person on the planet now, because I don't think I know enough about anything. But 84% said they had no learning needs. Was that a surprise to you?
I was surprised by that. I think maybe it speaks to kind of like what do people think an IPC learning need is? Like, does it mean that their hand hygiene training is up to date for the year and that they've, done the kind of mandatory stuff? Like maybe, you don't know what you don't know, So I suppose it's like tricky, like how do we deliver education to people that they don't know they need? And like, do they need it? Like, have we decided that this is education people need? Like, I don't know yet. Like, there's evidence that maybe we have, but like, I suppose, yeah, I was interested in that. And also I think it was interesting that the majority of people who do discard stuff, it's because they don't know not to, not because they don't have a better option. So I think that oftentimes it comes up like, oh, well, there's no other option, kind of what do you expect people to do? And I think that's really valid. But at the same time, like, people did report that they had other ways they could discard stuff that wasn't really disruptive to their workflow. But it was a lack of knowledge maybe that was, facilitating the behaviour. So I think maybe there is scope to maybe improve practices with education potentially, based on that report, like that kind of indication. But
I think that's a really important point, because a lot of times we jump to the people need more education and we don't think about the barriers. But as you articulated, that those barriers necessarily weren't there or reported to be there. So in this case, education might be, one of the things that's going to be more effective. I found the same thing, the very interesting point that we've just talked about learning needs, or not identifying the need for more training in this area. The other thing I really like, just touching on something you said earlier, Aoife, and that was, I think it was 45% of people or thereabouts said that they used the sinks for the purposes that we described, pouring stuff down them. But 82 or 81% or something it was off the top of my head, so they witnessed someone else doing it. So even the reported practices themselves, and then they say, but I've almost double that, I've witnessed people doing it. So it's interesting about this whole self-reporting, and it's probably always going to underestimate poor practice or suboptimal practice, for want of a better term.
I find it interesting when you talk about what people know and what they think they know, because as Aoife said, they don't know what they don't know. So I do wonder if it's worth going down the educational approach, give them 10 things like, did you know that sinks spread infection from multi-resistant gram-negatives? And then the follow-up, would you like to know more about it? And then you almost do like a learning needs assessment and try and phrase it in a way that actually piques their interest so they actually want to bother learning about it. Because as you showed in your survey, that a lot of people who non-IPC didn't realise that this was an issue. Do you think they don't get how it's an issue, why it's an issue? It's splashing from the sink that's the issue, not necessarily what goes into it. Because I get a bit bored, to be honest, reading papers that say, we looked down the sink and found CPE. And I always think, good, because it means somebody's washed their hands. It's the whole point of the sink. It's a hole you put contaminated material from your hands down, therefore there's stuff going to be there. But how can it get back out again? And I don't think people are really quite thinking about it in really that way, because most people, a sink is just a dirty, a hole in the corner to tip a liquid down. And I wonder if people consider it to be dirty because they wash their hands there, therefore this is a cleaning thing, rather than actually I'm just putting it into something that collects to the sewer. Have you got any ideas about how people might start make those connections?
I know Eve and I have chatted about this, and I suppose when she was going around the wards, I suppose one of the things that in a previous paper that came out last year, she was looking at how CPE can thrive in, nutritional drinks and enteral feeds. And I think for that, like, we actually went over to the dietetics department in the hospital to basically say, give me your 5 top enteral feeds and nutritional drinks. And I suppose even just talking to them about it, it was quite evident that they were interested. They'd be asking, well, what are you doing this for? And so there is an interest when you actually talk about it to people. But it does, I suppose it comes back to, in Ireland and that kind of period from 2017 to 2022, when we had that national public health emergency and we had all of those policies. And the policies were very much kind of geared towards person-to-person transmission, not as much about the environment. And really, when there was a reflection came out just before we kind of got involved in this study from the expert advisory group to the public health emergency team. And they really did say that drains are inadequately controlled when it comes to CPE. So I suppose, what we found from our study is that most people were very clear on the role of the kind of, the built physical environment, but really most people would kind of think, well, this is where we're supposed to dispose of waste. But, there is very clear, I think, guidance in terms of hand washing sinks should be used for hand washing only, so it's really about trying to get that message across. There are, of course, other things that can be done to try and avoid the kind of backsplash and, poorly draining kind of systems that if it does go down the drain, that it actually stays down there. But I suppose the other thing that's not maybe in the public kind of ether as much either is that we are putting these things down drains that could actually end up in the environment if they're kind of poorly managed by wastewater treatment plants as well. So, I suppose what we have to think about is what happens, in terms of the hospital environment with poorly draining systems, and also what's happening beyond the hospital.
In the survey, did you explore the other elements of CPE like workload or views on donning and doffing PPE or staffing? Were those types of things explored as potential, challenges with some of the CPE guidance, or was that not something you've done in this paper?
I think in this paper we didn't. We did ask people if they did pour things down the sink, what was the kind of factor that motivated it. And I think we did give people an option to say, it disrupts my workflow. And yeah, I think like it still kind of was borne out that actually it was mainly like a lack of education. So we didn't go too far into the kind of barriers to practice. I suppose one thing to add to kind of what Deirdre and Martin were saying as well, just to come in with in terms of education, I think one thing that we was kind of, I take Martin's point that like if something is in the sink, it's not so much a problem actually until it kind of comes back out again. And I think one thing that we've talked a little bit about but didn't explore too much was kind of how people interact with the sinks in kind of real life. And I think that would include patients. So I think a lot of the time the hand washing sink is actually in the patient room and it's really near the patient bed. So the patients, when you go to the hospital, you can see, and like this has been spoken about before, like the dentures are there in the pot. They're kind of almost probably using the sink to wash. They're using the sink to like wash their stuff and filling the sink with water, even if it's one of those ones with the draining hole at the back. And like that interaction, I suppose, as well, is something that we didn't explore in the survey, but is something that probably is a contributor as well in terms of patient interaction. I just think it's just worth adding that as well, that, on the one hand, like there's the staff interaction, which is pretty predictable. Like they're going to probably go wash their hands there. They're probably going to, maybe they're going to pour something down the sink. Like we're not really sure. And maybe that's going to facilitate a nice little CPE reservoir that's existing there. But I suppose like what we don't understand too much is kind of what the patients do. And I suppose that's where we're monitoring or tracking the acquisition. So I think that's something that would be really interesting to explore as well.
It's a good point. It's a good point because Hugo Sachs had a paper with Leila and Wolfersberger last year looking at modelling MRSA transmission and actually doing some sampling. And they found that most of the environmental contamination around a patient is actually the patient themselves moving around the contaminating surfaces and not doing that. So I think you're right about that. When I'm thinking about what go down the thing and what feeds biofilm, I've been unplugging a drain here at home recently because kids here got long hair and I'm pulling out stuff. But it's full of biofilm in the bath and in the sink. Now, I'm not sticking enteral feeds down or any form of liquid down there other than normal washing procedures. So it's skin squames and soaps and conditioner and that sort of thing that's going down there. So I'm not actively feeding it, I don't think, unless the kids are sneaking in there at the night and tipping cups of coffee down there or whatever. So
protein shakes.
Yeah.
Pouring
yeah,
whiskey
that's
down
true. Yeah, whiskey. Well, that's at least some sort of disinfectant.
Yeah, that's right.
But and my kids would never tip whiskey away anyway. There's enough carbon coming off our hands in skin squames and in soaps and that sort of thing to grow biofilm anyway. And I accept in hospital we can exacerbate it by putting highly nutritious material down there. But going back to working in Nightingale Hospital in one of these put-up units we had in London, we had an area that was used and an area that wasn't used, and it was only hand tide units going in there because the patients weren't eating or drinking in that area. And in the other area, we just ran water down there because we were flushing it. And Jeannie Moore came and had a look, and we had thick biofilm in the hand hygiene only sinks, and we grew Klebsiella pneumoniae, things like that, which is good because we actually never identified one in the patient, so we'd had stuff through and caused no infection. So I do wonder if we could ever really get on top of it anyway. And there are solutions like water-free care, etc. Is that the direction of travel at all in your area? Are people looking at restricting water or moving things away from sinks so there is like a zone around?
I don't know. I suppose in terms of the direction of travel, I suppose there's emerging evidence. Although there is evidence, and there's kind of maybe more evidence emerging that water-free care is the way to go. I suppose I'm not really sure of how close we are to that here, I think, and I just don't know the answer to that. I think there's definitely applications for it. I think I'm not sure that it's really kind of something that we're moving towards soon.
I can't decide whether it's actually just the removing of the water or actually stopping the use of the sink. Therefore, there's less splash.
I suppose there's a few things. Yeah, with the sink. I know we previously did some work where we kind of grew CPE in different soaps and stuff, and we found that even they were using the soaps as food, and as you say, that soap scum is so amenable to just staying around the pipes, and kind of the water just kind of stagnates around it. I think as well, one of the reasons that we started to look more at the enteral feeding stuff as well was because we were aware, I suppose, of the challenges of disinfecting drains. So it's kind of a separate thing, but sometimes, in a CPE outbreak, there's kind of this action to we need to do something, so let's disinfect the drains, and that's just such a difficult thing to undertake as well from a practical point of view. I have a diagram of one ward, and I think I had found I noted all the drains on it, and there was 75 drains on a 35 patient ward between all the different showers, toilets, sinks, the sluice, all the different things. And then with the contact time that you'd need for the disinfectant, that would take a whole you'd just be finished when it was time to kind of start again, really. That's just such a difficult thing to undertake. So one of the reasons that we started talking about maybe if there's things that we are doing, for example, pouring nutritional stuff down the drain, that's counteracting that effort, maybe that we should try and modify those practices because that's just such a difficult thing to deliver well. So I think it's just a really fine balance, isn't it, of you kind of want people to be able to do their job in the clinical environment and do the things they need to do without inadvertently maybe making a problem worse. But at the same time, what is the evidence to suggest, I think, as Deirdre and I were speaking about this, that this is a small piece of evidence, and it does seem as though the direction of travel generally is to kind of decrease transmission from sinks and, keep patients safe. And maybe this is one way of doing that in a kind of with a load of other things too. But I suppose translating that out into the non-IPC workforce, who are the people who would have to interact with it, that's a different thing. And I'm not sure what the next step is, to do that. Just because I just don't know, and maybe it's education, and maybe more evidence, or maybe just translating the evidence into a way people can understand, as you said, a simple kind of, do you want to know more about this, or did you know this? Here's some information that is going to make sense to you. That might be a really powerful way of doing it, as a starting point, and then going from there.
I mean, I get the point, Martin, about, of course, you're going to get hand bugs down the drain, and you are going to get biofilm. We've torn apart sink drains, and we do find very thick biofilms down there. But I suppose the worry for us is really the CPE within those biofilms and what they're doing, and we know that they're moving their genetic material around and that kind of thing. So I think, and as you mentioned, the more carb or the more organic material that's down there, then the less effective the disinfectants are going to be. So it just means that of all the bugs, CPE is just persisting down there much more, and we're creating conditions for that to happen, and for to really keep the party going down there for the CPE.
That's a good point.
Keep the party going.
I like that. Keep the party going. That party we don't want to have.
Yes, good, yeah.
Just in case people are interested in repeating this type of work in their own country, people contact you if they're interested in looking at your survey to perhaps replicate somewhere else, or have you put that somewhere already for people to be able to access?
We would be, of course, very interested in sharing that with people who are happy to do something similar in other settings in other countries. Absolutely, yeah.
I was going to ask the question actually. With the development of the survey, did you develop that yourself, or was it based on some existing surveys? How did you sort of develop that in the first instance?
We developed it ourselves, so we because we were kind of new to the survey game, I suppose. We read a little bit of literature about the kind of questions to ask and the kind of data you want to collect and stuff, and we kind of worked back from there. And then we have an internal in the university we work in, there's kind of support for study design and stuff, so we consulted with them as well, just because it was kind of different to the kind of research we usually do. Just, I suppose, because it was kind of once we started to get responses back, we wanted to make sure the questions were giving us the data we wanted, and so that we'd be able to kind of derive meaningful the information we wanted to get from it. And then we piloted it a few times as well with kind of locally with IPC, but then also importantly with non-IPC people to make sure it all kind of made sense and stuff. So it was kind of interesting because I thought the survey was in great shape, and then a few people did it and they were like, "This question, what are you talking about?" So I think that was really useful. So we were very grateful that some of our colleagues and kind of friends did that as well, because that made it better. And I think just having the questions so that people can only give certain answers was really important, because people initially we had some free text and people were giving really interesting kind of free text responses that I was just really interested in because I'm interested in things, but you wouldn't be able to analyze it in any kind of way at all. So that's kind of how we did it. Just I suppose because it's a bit different to what we usually do. So yeah.
Can I quickly ask one thing that just popped through my mind? You asked nursing and medical staff. Now you haven't reported those separately. I just wondered, actually, did the sync come up at all in the consciousness of the medical staff that you asked, or did they just get subsumed into the rest of it? Did they get it? Because, to be honest, half the medical staff I used to work with haven't visited a sync's locality for years. They might use alcohol hand rub, but you'll never often see them go into a hand sink. And they certainly won't be pouring drinks down or anything like that. So did it hit their radar? Did you see any differences that you weren't able to report that weren't significant?
I'm trying to think now. I think so. Our medical staff were predominant, so they were pretty much about either people who'd had some microbiology experience, so they had some kind of interest already, or people with kind of none. So I think when we looked at it, there was more of a people who had a microbiology experience, were kind of aware of the issue, but at the same time it wasn't really something that they did in their usual practice. Whereas the other people were less aware of the issue, and again they were disposing of things a bit less, I think, than nursing, because it's just not part of their usual role. Whereas the nursing staff who responded would have just been it's kind of part of their day-to-day, disposing of IV fluids, disposing of enteral feed. I think it was in the consciousness, it wasn't any less in the medical staff than any of the other groups that responded, as far as I know.
You obviously didn't ask any orthopaedic surgeons then. Okay, well, it's been fascinating. I've really enjoyed reading it. For me, the big jump out thing was, though, that people don't think they need to know anything else, which means either we're not communicating the fact that they've got a knowledge gap to them, or they really do think it's not important enough for them to want to know more either. So I thought that was fascinating. So good luck with the Viva and becoming Dr. Kearney. Really enjoyed chatting to you both, Aoife and Deirdre. Thanks very much for spending time talking to Brett and I today.
Thanks so much. Enjoyed it as well. Thanks.
Yeah, thanks so much. It's been great.
Thanks, Brett. Always good to see you.
Thanks, man. You too. And it's a wrap from us on this edition of Infection Control Matters.